Welcome to this pre-Congress session that's being sponsored by the EuroQol Group. We're very pleased to be able to have this opportunity to present this pre-Congress session. What we'll be doing in this pre-Congress session is presenting some new research from EuroQol around using new instruments in health economics research, so EuroQol instruments, some new instruments and some new applications. I'd like to begin, so I'll let everybody know that my name's Rosalie Viney. I'm from the University of Technology in Sydney, and I'm also a member of the Scientific Executive of EuroQol. So it's my pleasure today to be chairing this session. I'm coming to you from Sydney in Australia, so what I would like to do is begin by acknowledging the traditional custodians of the lands from which I'm coming to you, who are the Gadigal people of the Eora Nation. And I'd like to acknowledge those traditional custodians, pay my respects also to First Nations people across the world and across IHEA membership, and to pay my respects to elders past, present and emerging of all First Nations. So as I said, thank you so much to everybody. I'm actually going to start sharing my screen. And start my slideshow. I'm hoping that everybody can see that. Yes, okay, so this is just again to give you that quick introduction, and I'll give you a bit of an overview of what we'll do today. So the presenters today, so as I said, I'll be the chairing and moderating the session, and I will give a very short introduction to EuroQol instruments and the EuroQol Group, and then we'll have three other presentations that will be longer papers. So first of all, Nancy Devlin from the University of Melbourne and Mike Herdman from the Office of Health Economics will give us an overview of the youth instruments that EuroQol is developing and has been in the process of developing. Then Tessa Peasgood will give us a presentation on the Eq Hwb, which is a health and wellbeing instrument, which is another new instrument that EuroQol are developing. And then Juanita Hagsman will give us a paper which is around work that's been being done. In fact, I should go to my next slide because I realize I'm covering all of that, on what's called the popcorn study, which is health-related quality of life and mental health and wellbeing across 8 countries, looking at the impact of COVID using the EQ5D as a measure of health and wellbeing. So we'll have questions after each presenter, and as we've said, that will be via the Q&A function. And then we'll have some time for questions at the end. So pop your questions into the Q&A function along the way. So as I said, I'm just going to give you a very short introduction to the EuroQol Group and to the EQ5D suite of instruments in general. So EuroQol is an international network of multidisciplinary researchers with very much a strong focus on measuring and valuing health. It's got a really long history, a long and a proud history. So EuroQol as a group first met in 1987 with the aim of developing a standardized generic instrument to describe and value health-related quality of life. And out of that meeting and out of many subsequent meetings came the development of the EQ5D instrument, which is used in evaluation of health and of health programs. It's now the most widely used instrument internationally. It's been translated into most major languages, and a really important aspect of that is that it's got really carefully supported translation that's got enormous quality control behind it to ensure that the translations are really meaningful in each language. The EuroQol Research Foundation supports scientific research related to the development and use of the EQ5D instruments and related EuroQol instruments. It's a not-for-profit foundation, so it's helping to develop and continue that quality control and that development of the methods around the EQ5D suite of instruments. So the EQ5D, if you like, is a family of instruments that describe and value health. As I said, there's a long history, so a more than 30-year history of use in clinical trials, in registries, in population studies, so in a really wide range of studies. Importantly, it's a generic, standardized approach to measuring health with a standardized approach to valuing health as well, that then provides estimates for quality adjusted life years that can be used in economic evaluation. And I'll come to that in a moment in a bit more detail. So the features of the EQ5D, it's a really simple, generic instrument that's got comprehensive coverage. So it covers 5 dimensions of health: mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. There are 3 versions of the EQ5D that are currently developed, and there are, as we said, the EQ Hwb that's in development. So the EQ5D3L was the original version of the instrument, which had 3 levels for each of the dimensions. So 3 levels of mobility, 3 levels of self-care, etc. More recently, EuroQol has developed the 5L version, which has 5 levels. So that gives more sensitivity, and I'll mention a bit more about that in a moment. And then, as we'll see in the first of today's presentations, EuroQol has also developed the EQ5DY, a youth version that has 3 levels and is aimed at younger populations. So the language is around the same sorts of dimensions, but for younger populations. And then finally, as I mentioned, the EuroQol has also been developing, and this is what Tessa will talk about, the EQ Hwb, a health and wellbeing instrument. That's a new instrument that will assess a much wider range of effects of health and wellbeing aimed at care recipients and caregivers. So but very much with a health and social care focus. So just a little bit of more information about the EQ5D5L. So as I said, it was introduced later. It's a development from the 3L version with the aim of improving sensitivity. Like the EQ5D3L, it consists of a descriptive system, so the 5 dimensions and the 5 levels of each dimension, but also a visual analog scale in which people assess their own health on essentially a thermometer. It's also supported by a standardized approach to valuing health. So that's the EQVT protocol, which has been created to create standard value sets that then can be used in economic evaluation. And the method behind that is a composite time trade-off. We're not going to spend a lot of time on that today. And then it's supplemented by the use of a discrete choice experiment for valuation. So importantly, the EQ5D5L has been translated into more than 130 languages and has multiple modes of administration. And it's usefully explained in this animation, which I hope you'll bear with me to be able to show you the animation. So I'll need to stop sharing my screen and just a few moments, and I will pop up this animation. Let's go.
Explaining the EQ5D in about 2.5 minutes. To make healthcare decisions like whether a new medical treatment really works, or if it offers good value for money, or what the...
Apologies, everybody. I started it with...
Explaining the EQ5D in about 2.5 minutes. To make healthcare decisions like whether a new medical treatment really works, or if it offers good value for money, or what the impact is of a certain condition, we need to be able to measure people's health. One way we can do this is by looking at length of life and quality of life. While length of life is easy to measure, quality of life is more subjective, but we can measure it by asking patients standard questions about different aspects of their health. The EQ5D is a questionnaire that's been used worldwide. It's short, simple, and is one of the world's most popular measures of health outcomes. It was developed by the EuroQol Group, an international network of researchers. The questionnaire is made available by the EuroQol Research Foundation, a registered charity in the Netherlands. The EQ5D measures 5 dimensions of health: mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. Patients tick boxes to show how they're feeling in each of these dimensions. They also rate their overall health using a visual analog scale that looks much like a thermometer. All this gives us a description of a person's state of health. This description is then converted into numbers, which can be used to inform healthcare decisions. The EQ5D is available in more than 200 languages. Its flexibility allows people to complete it with paper and pen, digitally, over the phone, in face-to-face interviews, all through caregivers. And the EQ5D is evolving. The original gives people 3 response levels for each dimension. The newer EQ5D5L offers 5 levels to pick up more subtle differences in health. There's also a child-friendly version, the EQ5DY. Because it's generic, the EQ5D is versatile enough to compare health across different types of patients, diseases, and treatments. Extensive research shows that it's a robust, reliable, and responsive way of measuring health in a wide range of conditions and populations. And the EQ5D simplicity makes it easy to use in routine measurements, health surveys, and clinical trials. The EQ5D, helping the world make better health decisions. To find out more, visit www.EuroQol.org.
So I think I stopped sharing there a moment early and didn't give you the web address. So it's www.EuroQol.org. And I'm just going to go back to my presentation. To do today is hear more about the EuroQol suite of instruments and their use. So as I said, first of all, we'll have Mike Herdman and Nancy Devlin presenting about measuring and valuing health in younger populations, so on the EQ5DY. And then Tessa Peasgood will introduce the EQ Hwb. And then, as I said, Juanita will present on the popcorn study, which is looking at the use of EQ5D in measuring the impacts of the COVID pandemic. There's obviously a longer title there. So let me begin, and we can stop sharing my screen, and I'll start to introduce Mike and Nance. So we're going to begin with Mike and Nance, as I said, just to introduce them. They're both long experienced members of EuroQol with an enormous amount of research experience in measuring and valuing quality of life. So Mike will be presenting the EQ5DY instrument. And so just to introduce him, he's got a 25 years experience in working in health technology assessment and outcomes research. He runs his own consulting company, but he's also the head of health outcomes research at the Office of Health Economics and an honorary visiting associate professor at the Saw Swee Hock School of Public Health at the National University of Singapore. And I'm also going to introduce Nance at the same time. So Nancy is Professor of Health Economics at the University of Melbourne and a Senior Fellow Office of Health Economics in London. Again, enormous experience in measuring and valuing patient-reported health outcomes over many years. And she's currently leading a Medical Research Futures Fund project to develop methods to strengthen measurement and valuation of children's health in Australia. So that is the QUOCA project. She's got, again, both Nance and Mike have many peer-reviewed journal articles and much experience in this area. So it's a pleasure to have them to do this introduction. So can we go to Mike's slides?
Hopefully we can, Rosalie. Hopefully we can. Can you see those?
Yes.
Can you see that okay?
Looks good, Mike.
Yeah, okay, great. Thanks. And great to see so many people joining us. Well, what's this morning for me here in Barcelona. And I thought I'd just say a special welcome to any England fans that are joining us this morning or for this presentation. And congratulations on yesterday. So yeah, thanks very much for that introduction as well, Rosalie. I hope we can live up to your kind words. So as Rosalie said, what I'm going to do today is briefly sort of introduce EQ5DY, which is the EuroQol Group approach to measuring and valuing health in younger populations. I'm going to particularly talk about the measuring aspect of it, and Nance will touch more probably on the valuation side of things. So just to give a quick overview, because we don't have too much time, So let's get straight into it. So the idea of my part of this presentation is just quickly to introduce the EQ5DY, give an overview of its development for anybody on the call this morning who doesn't know the instrument particularly well. I'll also describe some of our ongoing EuroQol Group initiatives to expand the measurement and valuation of health, particularly into the very youngest populations. We look at the relationship between EQ5DY and EQ5D adult instruments, which would be the EQ5D3L and EQ5D5L. I'll also report on the current stages of a relatively new 5-level version of EQ5D that we've been working on and which we've labeled EQ5DY5L. And just to say that the context for this presentation really is that of looking at whether it's possible to get a core approach for measuring and valuing health, which we could then use across the full age range, which would be useful really in all sorts of ways. So that's the sort of overarching idea for this presentation today. So briefly, the EQ5DY is like all EQ or EuroQol instruments really, is a generic preference-weighted measure of health. So it incorporates utility weights for use in children and adolescents. We initially developed this way back in about, I think the publication was in about 2009, because at that time the only instrument we had was the EQ5D3L. And while that had proved useful and popular, we didn't really consider or think that it was appropriate for use in younger populations, certainly populations down below about the age of 12, just because of the way it's worded, and potentially because of the content as well. We weren't sure that it had been developed, the EQ5D3L had been developed principally for adult populations, so we weren't sure to what extent we could use it in younger populations. So the idea was then to develop a version or a variant of the EQ5D3L that we could use in younger populations. And I should say that the intention from the start was to follow as closely as possible the content and structure of the existing 3L adult version, with the idea, as I've sort of suggested already, of enhancing comparability of results and continuity in measurement across age ranges. The other important thing for us at the time was to make sure, if possible, that it would be a self-report measure, so that we'd be getting reports directly from the children as far as possible. So what we did was, we did this in 3 different broad stages. The first was an expert review of EQ5D to consider any changes needed, and then qualitative interviews with children. So the expert review came up with some ideas about how wording might be changed to make the instrument more suitable for children. And in qualitative interviews with children themselves, we explored the different options for changing the wording. The results of that stage showed that the content was largely appropriate and acceptable in children from about the age of 8 years up, as long as we introduced some modifications in wording, which we'll see shortly. Once we had the new version of EQ5DY and we'd run it past small focus groups of children, we then tested the measurement properties in larger population samples in several European countries, and it showed satisfactory reliability and validity. And in fact, further psychometric analysis over the years in patient population studies have shown it to be generally reliable and valid in other contexts, to the extent that in a recent review of preference-weighted measures for use in children, it was said that EQ5DY has the largest amount of evidence of good psychometric performance in proportion to the number of studies performed. So overall, a questionnaire which we showed was appropriate for children and which has shown generally good or very good psychometric properties. So for those of you who haven't seen the instrument, there it is. As I said, the idea was to stay as closely as possible to the original 3L format. So we've got the 5 dimensions: mobility, looking after myself, usual activities, pain, discomfort. And you see at the bottom there, instead of talking about being anxious or depressed, we talk about feeling worried, sad, or unhappy. So there were some changes or differences with the EQ5D3L, the adult version. And I've put them up side by side there together so you can get a brief initial look at the differences. So for example, as I said, the wording of the anxiety depression dimension has changed. For example, in mobility, instead of I am confined to bed, we say I have a lot of problems walking about. And we look at some of those differences in a bit more detail later on. So I'm not going to linger on this slide at the minute. The other important thing I think to say about EQ5DY and EQ5D instruments in general, and I've already mentioned it, is that they're designed not just to measure health, but also to value health, for particularly for use in economic analysis, but in other contexts and settings as well. So if we imagine, for example, here a child, an 11-year-old child, for example, with asthma, who might, on the day of the interview, self-report his or her health like this. No problems in mobility, no problems looking after myself, some problems doing usual activities, some pain or discomfort, and for some reason, in the mood dimension, they report themselves as being very worried, sad, or unhappy. So those are the codings we use for those responses. So for example, if you have a response at level 1, then that's simply coded as a 1, a 2 is a 2, and a 3 is a 3. So very simple, which then gives us this health state. So anybody when they respond to EQ5DY on the day of the interview will be in a given health state. In this case, it would be 1, 1, 2, 2, 3. And these are the health states that we use and which are particularly important for combining with societal preference weights for the health state. And those societal preference weights we obtain by using econometric techniques or methods such as time trade-off or discrete choice experiments, etc. So that's the other very important aspect of EQ5DY and EQ5D instruments in general. Again, I'm not going to particularly go into that, but I thought I'd flag it up because it'll be relevant for Nance's presentation particularly. Okay, so we had our instrument, but the other thing we needed to think about was in which kind of populations and how we would use it. Because even though we adapted the wording to make it more amenable for children, it's obviously clear from that initial investigation, it was fairly clear that below about the age of 8 years, we wouldn't really be able to get self-report from people using the instrument. You might be able to get it from some 6 or 7-year-olds even, but certainly not from all. So what we decided early on was to say that our self-report EQ5DY, which you can see here, would be the instrument to be used primarily. It would be our recommended instrument for the age range 8 to 12 years. So self-report whenever possible, just sort of fit with the PRO paradigm of subjective measurement of health. But we did have a proxy version, i.e. a version which could be completed by parents or other caregivers, which we could use if self-report wasn't possible for any reason. So it's important, this idea of self-report and proxy, particularly in children and younger populations, is important. Proxy measures are often used anyway. Maybe from some time ago when it was potentially thought that children couldn't provide reliable and valid self-reports, which has been disproven over the years. But it is more common, certainly, than in adult instruments to have proxy versions available. So we do have proxy version for that age range as well, or which could be used in that age range as well, if necessary. Below the age of 8, or from the age of 4, let's say, to the age of 8, we recommend only using the proxy version for the reasons I mentioned. Self-report in that age group is a bit tricky. Above the age of 12, from 12 to 15 is a bit of a grey area. You could use either the self-report EQ5DY or the standard EQ5D, and that would depend a little bit on study characteristics. So for example, if you had a study which was largely younger children, you might want to use just the EQ5DY here to make measurement homogeneous across the age range. If you had more participants from this upper age range, where you would be using more the EQ5D 3L or 5L, then our recommendation would be to stick with the EQ5D 3L or 5L in this age range as well, again for purposes of consistency of measurement within a given sample. Above the age of 15, we think that it's preferable to use just the standard adult version of EQ5D, either the 3L or the 5L. So those are our recommendations on how to use EQ5DY. But you'll see there are sort of, there's certainly a gap here. What about here? At the minute, we don't have any instruments covering that age range, or not official versions, and that's one of the things I'm going to talk about today. And what about at this end? If we, for example, end up using a mix of Y in adult versions in a big particular sample, how far can we compare or aggregate those results? Or what about if we're transitioning between pediatric and adult care, for example? So you start off using the EQ5D and then you move to the EQ5D 3L. How far are results at those two different stages going to be comparable? So those are some of the things I want to really focus on today and talk about our approaches to expanding measurement and making measurement more precise in those areas. So in that lower age range, from 0 to 4, I'm going to talk about two relevant research initiatives within the EuroQol Group. One is an adapted version of EQ5DY, which we're planning to use in caregivers of children aged 2 to 4. And the other initiative is a brand new instrument, really, which has become part of the EQ or EuroQol stable, which is called the TANDI, and that's to measure and value health in infants and toddlers aged 0 to 3. So, looking at the adapted proxy version for 2 to 4-year-olds, the background to this is that really there are relatively few preference-weighted measures of health for children under 4 years. There are some out there, but very few, certainly in comparison to older age groups, which hinders assessment of effectiveness and cost-effectiveness of treatments in this age range. And of course, that's important because children under 4 years tend to be greater consumers of healthcare. So it's probably an age range we want to be working in as well, or have tools to be able to measure and value health. So the aim of this study was to explore parents' views on whether EQ5DY is suitable for use in children aged 2 to 4, and to co-design with parents a suitable adaptation for further testing. So this was quite an interesting initiative, let's say. Because, as I've said, there are a few instruments in general, really, for measuring health in these very low age groups. So it was interesting to see whether EQ5DY would be acceptable to parents of children in that age range. And this study took place in Melbourne, Australia, with focus groups of parents of young children attending the Royal Children's Hospital in Melbourne. You can see the numbers there. There were a mix of mothers and fathers, a lot more mothers, as is usual in these cases, and a mix of children with moderate to severe health conditions and parents of well children, or those with only minor complaints. And the idea was to elicit opinions on the relevance and interpretation of the EQ5DY dimensions for that age range, and whether they'd be appropriate for use in that age range, and whether anything is missing from the measure. So on the basis of those results, we produced a preliminary adapted version, which was then further evaluated in interviews with 7 of the original focus group participants. So overall, and I'm just really skimming what was done here because we haven't got that much time, and these results will be presented and published later on, I've no doubt. So overall content, maybe a little bit surprisingly, was considered appropriate. But it was considered that there was some modifications to wording were needed as well. So you can see some of the caregiver comments there, things like mobility being considered broader construct than just walking, or for example, in self-care, a 2-year-old might be able to undress themselves slowly or just be learning, whereas a 4-year-old is dressing herself several times a day. So that's an interesting comment as well, because it's an age range where there are very, very sort of rapid changes in functioning and all sorts of aspects of what the child can do, which is something we have to take into account as well. So, and these slides will be available, so I'm not going to go into everything you can see there, but you can look at them with more time afterwards. So, because I'd like to move on and just show what the draft version that we've come up with for this age range, how it looks at the minute. So as you can see, it's very similar to the EQ5D standard proxy version. but there are some differences. So for example, instead of talking about walking about here, we talk about movement, so it's a bit more general. We've added examples of the type of things we're talking about with looking after themselves or doing usual activities to all of the dimensions, not just the usual activities dimension. Also an important thing is this specification really that we're talking about. Do they have problems or no problems within each dimension, thinking about it, what would be age appropriate for those children. So again, it's fairly similar, but there are differences. It's more specific, it's more directed at that particular age group. So again, you have a chance to look at this in the slides afterwards. And that's where we stand at the minute. So we have that version. What we need to do now is to test it, and that's what's happening as we speak. So we're looking at the assessment of acceptability, reliability, and validity in 400 proxy completers. Once we've got that, we'll review the results and decide whether or not further changes are needed. And eventually, with the hope that it'll be considered suitable to be an official EuroQol version. Okay, so that was the 2 to 4 adapted version. The other new instrument I mentioned is the TANDI, or Toddler and Infant Health-Related Quality of Life Instrument, which again was developed by EQ Group researchers for children to measure and value health in children aged 0 to 3 years. And again, developed because of this relative lack of generic preference-weighted measures for use in this lowest age range. Again, based very much on the Eq5D model, but you'll see that there are more differences this time with our standard Eq5DY. So it's generic, limited number of dimensions, limited number of well-defined levels of severity, etc., and amenable to valuation, which is a key feature for our instruments. It was developed through a systematic review of items and dimensions of health relevant to the youngest populations, and several or numerous interviews with caregivers of very young children to discuss and generate content. There were Delphi rounds of that content with experts in the measurement of child health. Alpha and beta testing to reduce item numbers. And finally, psychometric testing in a total of 187 caregivers of children aged 1 to 36 months, with acute illness, chronic illness, and from the general population. So that's the only psychometric testing that's been performed to date. That's the measure as it stands at the minute, the current draft version. As you can see, the format, the layout, etc., is very similar. In this case, there are 6 dimensions. You can see that there are substantial differences really here with the Eq5DY. But overall, you can definitely see that it forms part of the same family of instruments, if you like, and is very much designed to be able to be used to value health states as well. So again, the slides will be available, so you can have time to peruse this at leisure. What are the next steps here? Well, so we've got the current draft, which has shown good measurement properties in 1 study to date. At the minute, this is considered an experimental version by the EuroQol Group, which is important. So further research is needed. We only allow limited distribution of these experimental instruments, and it's for methodological work only. So priorities in the future will be assessing the cross-cultural validity of the measure, with further international input on content from both child experts and caregivers. We also need to look at the feasibility of valuing the TANDI health states, and we definitely need further assessment of measurement properties in different conditions and settings. And just out of interest, there'll be more information, a lot more information on the TANDI at this organised session within IHEA as well. So I highly recommend going to that if you can make it. So there we are, with the TANDI and the adapted proxy version for 2 to 4-year-olds. We potentially have a suite of EuroQol instruments to cover the whole age range from 0 years and up. But the other thing I mentioned at the beginning was the comparability with the adult versions of Eq5DY. So transitioning between pediatric and adult care, for example, or mixing Y and adult versions. We saw some of the differences between Eq5DY and 3L earlier on. They're highlighted more here. So for example, we talk about looking after myself in the Y, self-care in the 3L, a lot of problems walking about, I'm confined to bed, a lot of pain, discomfort, extreme pain, discomfort. So although they're very similar, you might wonder just to what extent we can compare results, and especially if we're mixing results from the two instruments within the same study, within the same sample, or if we're transitioning between pediatric and adult care, how far can we compare and aggregate results? Unfortunately, we have no publications yet on looking at these aspects. It's something that we haven't really focused on it today, but it is something we are going to start focusing on because of this interest in continuity of measurement across the full age range. So at present, all we've got is an ongoing study in South Africa and Ethiopia, which aims to assess agreement in results on EQ5D and Y in respondents aged 12 to 16 years with and without health problems. South Africa focusing on a comparison of the 3L and the Y3L, and Ethiopia comparing results on the EQ5D5L and the new EQ5DY5L. So data collection is ongoing and results may be available early next year, hopefully, if COVID and other things don't get too much in the way. But we'll definitely need more studies, I think, in the future to understand the possibilities of continuity of measurement at that upper age range. So we're getting to the end. Just the last thing I wanted to talk about was the Y5L, which is our newish version of EQ5DY. There is a publication cited at the bottom there, Simon Kramer et al. So you can find out more about that there. That's the version. As you can see, very similar to EQ5D5L, maybe more comparability between EQ5D5L and this new version of the Y than the 3L and the standard Y, for example. But that's we've yet to see. So there have been several studies published or are ongoing to measure the measurement properties of this new version of EQ5DY. And results to date, I would say, appear to show equivalent or superior performance to the Y3L. But it is, as I said, currently considered still an experimental version. So you have to sort of get a special permission, if you like, to be able to use the instrument at present. And there's got to be methodological aspects to the research as well. However, we are planning to review studies looking at the measurement properties of the Y5L later this year to decide whether the version can be moved to beta status, in which case it would be available for wider distribution. And we're also planning methodological work on valuing the Y5L. Nothing's been done on that front yet. So that's me. I hope I haven't run too much over time. And again, I'd just like to say thank you very much for joining us, and that you can get more information at these sites, as Rosalie mentioned, www.euroqol.org. There's an introductory video on YouTube to EQ5DY, which you should try and look at if you can. It's quite good fun. And as I mentioned, more information on the Tandy at that session on the 14th of July. So thanks very much.
Thanks so much, Mike. Now, I will mention that one of our colleagues, Aureliano Finch from the EuroQol office, is also on the session as a panelist, and he's answering questions along the way if they come up, and has been monitoring them. I'm going to, in the interest of time, go straight to Nancy Devlin, who I've already introduced, who's going to continue telling us more about the value set side of the EQ5DY. Thanks.
Great, thank you, Rosalie, and hello everyone. I'm joining tonight from New Zealand, where it's currently very dark and very cold and very snowy outside, so very envious of all the lovely weather that you've all got in the Northern Hemisphere. So I've been asked to present on the state of valuation research for the EQ5DY, building on what Mike was just explaining around the measurement side of things. So without further ado, what I'm going to be talking about today is why we need values for EQ5DY, some of the methods questions that we've had to address in building toward value set studies, the current protocol and experience with using that protocol and what the current status is of value set studies around the world. I'm going to talk a little bit about whether or not we can treat the values coming from that protocol as being strictly equivalent with adult values, and what the implications of that will be for their use in cost effectiveness analysis and HTA. And then a bit of a look ahead at the research which is currently being undertaken and will be undertaken in future, and what we're planning to do about consulting with HTA bodies. So just to begin then by talking a little bit about why we need values for the EQ5DY. A characteristic, the distinctive feature really of EQ5DY instruments generally is that they're concise, they're generic, and they're accompanied by values, and that's what gives them that sort of very broad applicability. And they aim to facilitate broad comparability in general, and with respect to the EQ5DY, it means that we want to be able to use the instrument to compare health across dissimilar childhood conditions and between child patients and children and the general public. But as Mike highlighted, the instrument also follows the general content and structure of the adult version of the EQ5D 3L. And the intention was that that would allow, in principle, for comparability of results and continuity of measurement across that whole age spectrum. So that was sort of the goal. Now, the values, of course, they provide a means of summarizing the profile data that come from these instruments, and that is also the case with the EQ5DY. It summarizes profile data into a single number, and that single number, as you know, reflects how good or bad those health states are overall. They have the characteristics of being anchored at 0 and 1 for dead and full health respectively, which is what we need when estimating QALYs for use of cost-effectiveness analysis. Cost-effectiveness analysis isn't the only application of EQ5DY data, though, and I just want to mention that, of course, we know from our colleagues in clinical settings in Australia, it's being used in routine outcomes measurement in paediatric clinics. It's being used as part of child population health surveys and so on. It's important not to forget about those other applications as well. And I just wanted to highlight, you're probably aware of this book anyway, but it's available free to download at the link in these slides. It's called Methods for Analysing and Reporting EQ5D Data, but everything in that book can also be used with respect to the EQ5DY as well. And I guess the point I just wanted to make very briefly here is that values are not always required or always the most relevant way of summarizing profile data. If you simply just want to have a single number summary for statistical analysis, for example, it doesn't necessarily require the use of values. But of course, the values are crucial for supporting the use of the EQ5DY in economic evaluation. So let's go on and talk about those values. So as the EuroQol Group started to prepare for valuing the EQ5DY after the publication of the instrument, and was obviously thinking about that beforehand as well, you very quickly start to realise that every single methods question that arises in valuing adult health-related quality of life also applies to child health-related quality of life. Plus, there's a whole heap of really tricky additional questions which are specific to valuing child health-related quality of life. And some of these can be informed by evidence, and the EuroQol Group commissioned quite a wide program of methodological research as it prepared for launching a protocol and launching value set studies. But that evidence base can only get you so far. Ultimately, you need to make some value judgments, for example, about whose preferences are relevant. It's very important to note that we're highlighting all of these questions here with respect to the EQ5DY, but they're actually common to all child-specific instruments. So, for example, the usual question applies: what stated preference methods do you use? There's all the normal methods that we would talk about here, time trade-off, including the possibility of lead time TTO, lag time TTO, or a composite TTO approach, as is used in the adult protocol for valuing the EQ5D 5L. Standard gamble, which has tended not to be used in the context of EQ5D instruments at all. Discrete choice experiments, with which we now have a considerable amount of experience in the context of adult instruments. Visual analog scale, which was a method very widely used at the beginning and very much less so now. And there are other methods around as well, including the better than dead approach, personal utilities function approach, and so on. So you need to make a decision about which value method to use. Secondly, whose preferences to elicit. So the standard answer to this is adult members of the general public when it comes to valuing adult EQ5D states. But what about when we want to value states that are specifically those of children? Do we ask children and adolescents for their preferences and how good or bad they think these health states are? And do we, if we do want to ask children or adolescents, do we want to ask them if they're experiencing health conditions, so patients, or do we want children and adolescents in the general population? Quite a complex set of normative issues there. The norm, again, would be to ask adult members of the general public, and we know that some child-specific instruments, such as CHU9D, have taken that approach to valuing that instrument. But then that raises the question of what perspective to adopt and what we're asking adults to do in that context. Is it an adult being asked to imagine a state described by the EQ5DY as if experiencing it themselves as an adult, or imagining what that state would be like for a typical child or a hypothetical child, or imagining what it would be like for their own child or when they were a child? There's a whole range of different potential approaches here. What age of child do we want to ask people to imagine a health state being experienced by children of different ages, different age categories, or just select a single age? And what duration, how long will each of the health states be experienced for? Single duration, varying duration. Again, by convention, as you probably know, the EuroQol Group has tended to choose a 10-year duration, but it is a bit arbitrary. And of course, when we're talking about childhood health states, that means that potentially that duration will take you into adulthood. So here's our current protocol for valuing the EQ5DY 3L. It was published in Pharmacoeconomics last year. So we do now have a protocol. You can click on that link on the word protocol and it will take you through to it. And on the basis of methodological work, experimenting with different ways of eliciting preferences, weighting preferences, anchoring them and so on, these were the methods which were chosen, which stated preference methods, predominantly the use of DCE here, and I'll come to in a moment explain a little bit more why that is, but it has in particular to do with a challenge that you face when you ask adults to use trade-off based methods, where the trade-off is against length of life or risk of death. Potentially an unwillingness to trade affects the values. So the use of the CTTO approach here is specifically to anchor, and the protocol suggests that this can be done in separate samples, so a very large sample of DC responses, a smaller sample, which can be a non-overlapping sample, completing the CTTO tasks. Asking adult members of the general public, imagining the health state being experienced by someone else, where that someone else is a typical child. The age of the child is selected to be 10 years old. You could say that that's arbitrary. On the other hand, you could say that the EQ5DY is aimed at self-completion between 8 and 15, so it kind of sits in there. And the duration is set at 10 years for the states, as it is for adult health states. And here's the current state of play with respect to the value set studies, which are either completed or underway around the world. And I think it's worth noting what an astonishing achievement this is. This is a really large program of research when you look at this body of work underway around the world, given that the protocol was only published in 2020. So completed and published so far are EQ5DY value set studies for Japan and Slovenia, and well done to those research teams for being so quick off the mark. Belgium, Germany, Netherlands, Spain and Indonesia have all completed their data collection and are busily either modelling the data or finalising manuscripts. Studies are underway in China, Hong Kong, Hungary and Australia, and currently under discussion are potentially value sets for the EQ5DY for the UK, US and Canada. So you can see that we're starting to cover off some of these really important countries in terms of HTA. Each of these studies are encouraged to embed methodological arms. It's something that the EuroQol Group is very strong on encouraging, with the aim here that we continue to learn as much as possible from every single study which takes place. So that's something that we're very much encouraging at the moment. Experience to date with the protocol. I think it would be fair to say that the DCE design is working really well to generate latent scale values that have plausible face validity, and that this is completely non-problematic in terms of people being able to undertake the task and generate values on a latent scale. The protocol included 10 health states, which were to be valued using the composite TTO approach. The PIT state in the descriptive system, plus 9 others. And those 9 others were there to kind of address scale effects or context effects. So to provide some context to thinking about the worst health state to be valued. And the idea with undertaking that CTTO approach was that this would provide the preference data that would enable us to anchor at 0 based on 33333, or using all of the TTO data across the 10 states via mapping approaches or via hybrid modelling. And the protocol says that it's important to remark that the CTTO design corresponds to a minimum requirement that doesn't prevent researchers from adding more health states to that design if they wish. And our experience to date suggests that the TTO design and those 10 states, while it does support anchoring based on the PIT state, it's not as good as it should be when it comes to facilitating hybrid modelling. And actually, many of the studies that have already taken place and where data collection has been completed have already adapted that design for CTTO and extended the number of states, for example, to 28. So I think the current protocol provides a good set of guidance, but we certainly wouldn't regard it as prescriptive. We're very much continuing to pursue methodological research to learn from it. So how can the EQ5DY values that we've generated so far be used? And I wanted to highlight just the this paper, which was published from the Japanese value set, and point to a quote there, which I think is very thought-provoking. So they state in the paper that the EQ5DY values can be used to compare quality of life across different groups of children, but can't be used to compare levels of quality of life between children and adults. And they go on to say that children and adults have different values attached to very similar quality of life outcomes as a result of this value set, and that would lead to differences in estimates of qualities gained. And because the EQ5DY values tend to be higher for child health states than in comparable EQ5D adult states, a similar degree of improvement in an adult health state will generate fewer qualities than for a child. So simple comparisons of cost effectiveness ratios for children and adults should be avoided. So it's quite an important statement in that paper. And there's probably quite a bit to unpack there that would go beyond this presentation, but just to say that it is something that the EuroQol Group is thinking about very carefully and doing quite a bit of work on. So the question is, are the Y values generated from the protocol comparable with EQ5D adult values? And it is important to note that the methods used in the current protocol, while they echo the methods used in the adult protocol, in the sense that it uses TTO in combination with DCE, the tasks themselves are fundamentally different from those used in the adult protocol, because an adult member of the general public is being asked to value health in another person, and that person is specifically identified as a child. And we think what we are seeing from the emerging characteristics of EQ5DY values is that the values are higher compared to adult comparable states. And this is potentially because of unwillingness to trade, as I alluded to earlier on, an unwillingness to trade off length of life in a child when that child is already indicated in the TTO task to have a shortened span of life. So you end up with this kind of compressed scale of values. And potentially that means that the values mean something a bit different than the adult values, undermining potentially their comparability. I think we're also potentially starting to see differences in the relative importance of dimensions in the EQ5DY as opposed to the adult values. And that's very interesting and absolutely fine. A caveat on all of those comments that I've just made is that those comments are drawn based on data from a relatively small number of studies, which we have access to data to at the moment. And the findings certainly aren't uniform, but it's a suggestion of where the general trend is going here. If that was the correct trend, and if the values that we're observing for the EQ5DY are considerably higher than they were for adult health states, it raises some questions about what that would mean for their use in CEA and HTA. I mean, the catalyst to valuing the EQ5DY is that it is a different descriptive system, and Mike's slides made that extremely clear. So, for example, we've got sad, worried and unhappy as opposed to anxious and depressed, and we've got unable to walk about in the 3-level version of the Y as opposed to confined to bed in the adult 3-level version. So we've got age-specific values that have come from the fact that we've got an age-specific descriptive system, but they haven't come about as a result of a demand from decision makers for having age-specific utilities. And HTA bodies generally don't use age-specific values for any other groups, such as the elderly or other socio-demographic groups. So, and of course, the problem that we've potentially got is that the different characteristics of the values, the fact that you've got a more compressed value scale for the Y than you do for the adult versions, creates issues when you put those into a cost effectiveness model. So even if you were specifically looking at a child intervention, at some point, for example, in lifetime economic evaluation models, you will go from childhood health states and transition into adult health states. And you have this kind of cliff edge effect where you suddenly go into utilities with different properties. And it also means that if you're comparing quality of life utilities and qualities, then you end up with quantities that are meaning potentially very different things. The concern is that the higher values for the EQ5DY reflect adults' preferences, that is, adult members of the general public, i.e. society, preferences for prioritizing children, and very special preferences about the importance of longevity in children in particular. And HTA committees may well prefer to consider that in a more coherent, explicit way alongside other factors via their deliberative processes, rather than having those special considerations embedded within the value sets. That's an open question, and really a question for HTA bodies. Our ongoing work is looking at that issue and what the potential solutions would be if you wanted to create consistent values for both child and adult health-related quality of life. So very quickly, ongoing research that we're doing in the EuroQol Group. Mike's the chair of the Younger Populations Working Group, which I'm on as well, and we're spending a lot of time thinking about these issues. There are at least 2 projects doing an in-depth exploration of normative principles, going right back to first principles to talk about the relationship between that and the methods. There's testing of new methods, such as the parental TTO. That's a study underway in China at the moment. Very clever approach where it changes the nature of the TTO. The health state is still experienced by a child, but the trade-off happens against the parent's length of life, not the child's, as a means of trying to get around that unwillingness to trade. There's ongoing testing of each of the key elements of the protocol tasks and design, the perspective and the framing of the tasks and so on, through those methodological studies I mentioned are taking place alongside each value set study. Ongoing investigation of alternative ways of anchoring the latent scale DCE data. New methods, we're thinking about new methods for establishing an exchange rate between the adult and the youth values. And we're starting to look ahead at the identification of methodological issues specific to valuing the 5-level version of the instrument. So I guess the bottom line here is the EQ5DY through our value set studies will continue, but there's going to be a renewed commitment to each of those containing very strong methodological elements. We really want to continue learning from these studies. We're not actively pursuing EQ5DY 5L value sets at the moment, but all of the methods work that we're doing at the moment will ensure that we're very well prepared for that when that time comes around. And just to finish off, one thing that's emerging really, really clearly from the work that we're doing at the moment, particularly around the EQ5DY, is how important it is to consult with HTA bodies and other stakeholders or decision makers that might want to use this evidence. The EuroQol Group recognises it's really crucial to ensure that values are fit for purpose for use in decision making. One of the challenges there is that decision makers may or may not have very well formulated views on what the relevant normative issues are. There's awareness of the issues around both measurement and valuation. That's growing, and Rosie Lovett and others of us ran an HTA roundtable toward the end of last year with HTA bodies around the table to have an initial discussion around this. But I think it's really clear that engagement is going to require a combination of very careful briefing about the issues and then consultation with the relevant parties. So one of the things that we'll be doing over the coming months is developing resources and approaches to support that for all studies going forward. And we may choose to signal the importance of it by actually making it prerequisite for future EQ5DY value set studies. So just a couple of acknowledgements and disclaimers to note. And with that, I will hand it over to Rosalie. Thank you.
Thank you so much, Nance and Mike, for that fantastic presentation on both aspects of the EQ5DY. Now, as I mentioned, Ore has been answering the questions in the chat, but I might just ask him if there are any specific questions that you have not been, or sorry, in the Q&A function, that should be raised with Mike and Nance. Of course, Mike and Nance are free to look at the questions too. So maybe while Ore is turning on his microphone. So one of the questions is, what are the challenges in measuring health-related quality of life in developing countries, and why the method hasn't been used routinely in those countries? And there was another question around asking whether there are plans to use for translation, adaptation and valuation for one or more countries in Africa. I know that's the case for the 5L instrument, but perhaps for the Y we should have answer that question too. They were the main questions, I think, that hadn't been answered, Ore?
Yeah, that's correct. That's correct.
So
there was also a question regarding anchoring and whether the anchoring on the state 33333 is the most appropriate approach, or whether there are other alternatives that we're considering.
So on the measurement side, shall we turn to Mike first to answer those questions, and perhaps I'll pick up the anchoring one?
Yeah, sure. I actually couldn't catch, and I was looking through the Q&A, but couldn't see them. What were the specific questions, Rosalie?
So really the questions, there were two questions. One was around development, plans to develop translations for Africa, for one or more countries in Africa. And then the other one was around the challenges in developing countries.
Yeah, so great questions. I mean, I think as Rosalie mentioned at the beginning, one of our key objectives really is to make sure that we have translations available for as many countries as we can, and we have a very rigorous translation procedure that we apply in all of those cases. So we'd definitely be keen to have translations available in African countries or anywhere else, really, following those guidelines. That would be the key, I think. So the way we normally work it is that, I mean, we won't go out and say, right, we need translation for 5 countries in sub-Saharan Africa. We wait for requests from those countries. So if we get a request from somebody that wants to use EQ5DY in a country, then we would begin to talk to whoever wants to use it, and we would decide the best way forward. But we would do it through agencies, dedicated agencies who provide those sort of translations. But in some cases, we're also willing to do it by working with local researchers as well. So it depends substantially on the country and the experience of the researcher. But the overall message, we're definitely keen to have more translations in Africa and anywhere, as long as they're done well, I think. And the use in developing countries, again, the same thing. I mean, for me, we do work, people are working with EQ5DY tools in several African countries at the minute, especially, I would say, Ethiopia is one that springs to mind. Egypt is another. There are countries where it's already being used and quite extensively, quite a lot of work being done, but we could definitely do more. So again, overall message, get in touch. And we can see what we can do.
Thanks. Now, in the interest of time, I think that the other question had been answered in the Q&A, but feel free to add to the discussion there. I think we might go to Tessa's presentation now. So Tessa's going to give us an overview of the EQ Hwb, and while Tessa's bringing up her screen to share, I will just give you an introduction to Tessa. So Tessa's got again, extensive experience in this area. She was a senior health research officer at the University of Sheffield at SHAR, but she's relatively recently moved to the University of Melbourne to the School of Population Health and Global Health, where she is the Deputy Director of the Health Economics Unit, and she has ongoing research in economic evaluation, and particularly in this area of measuring benefits. So thank you, Tessa.
Thanks, Rosalie. Before I begin, I would just like to take a moment to acknowledge that I'm joining the session today from the traditional country of the Gundungurra people, and I would like to pay my respects to elders past and present, and also recognise and respect their cultural heritage and their traditional relationship with this land. Okay, so just a little bit of kind of stepping back in time. This instrument that I'm going to talk about today, the EQ Hwb, which is kind of now one of the sister instruments for the EQ5D, began its kind of first initiation with a team of researchers at Sheffield University at the School of Health and Related Research. And in part, I think it began because we had an interest in well-being, and particularly subjective well-being. And quite a bit of our research was trying to explore questions around, is well-being useful for public policy? What role does well-being and subjective well-being have in economic evaluation of healthcare? And this kind of created some motivation to think about potential for a new instrument within the utility space. And some of the concerns that have been sort of fairly well documented were around the fairly tight health focus of our commonly used utility instruments, and the fact that for some groups this might miss really important aspects of quality of life. And the groups that we were particularly interested in were people with very long-term conditions where an intervention in health may not be trying to change the health status, but it simply might be trying to improve somebody's quality of life. We were also interested in people with a disability and people who were receiving what in the UK we use the term social care, but generally other countries might use the term aged care, but we're particularly interested in people who receive care to help them with their day-to-day living. We're also interested in the fact that when we do economic evaluation, we're generally pretty good at taking into account the impact that interventions might have on patients, but many of those interventions will also have an impact on the carers as well, and informal carers. Now, the way that economic evaluation was kind of moving was to think about capturing these really important quality of life benefits. But some of the approaches that have been used to do that was to design separate instruments to sit alongside our main health utility measures. So in the UK, some of the kind of important measures that have been used are one called ASCOT, which is to measure social care related quality of life, so particularly for aged care interventions, and also the ICECAP, which is a capabilities measure. Again, there's other versions, but the ICECAP-O is again for aged care. However, if we have lots of different instruments, then we may have some problems with comparability. And if we acknowledge that even if we want to tap into social care related quality of life, we may still care about health aspects as well, in which case we have a bit of a challenge as to, well, do we want to use a social care instrument or do we want to use a health instrument? If we think both of these aspects are important, should we use them both? In which case we have some problems with double counting. So one of the potential solutions that we certainly thought was worth exploring was to come up with an instrument that had the potential to capture not just health, but other aspects of quality of life that was likely to be important for interventions for people with long-term conditions, for the elderly, and for carers. And that gave rise to what we called the Extending the QALY project, which was a very large international collaboration of researchers. And it was led by Professor John Brazier at Sheffield. But as you can see from the screen, this had a lot of input from many people. So in the UK, we had collaborations with the University of Kent and the Office for Health Economics, but that was now moved into University of Melbourne through Nancy Devlin and now myself at Melbourne. We also had close relationships with the National Institute for Health and Care Excellence. And we were really fortunate to be able to share the project with staff at NICE all the way through the development of the project. And so they contributed not just the names you see on the screen, but other members of staff from NICE contributed and gave input throughout the project. You'll also see there's 5 other countries with groups of researchers who were involved in the development of this instrument. So we had input from China, the USA, Argentina, Australia, and Germany. In terms of the funding side of this project, I would like to acknowledge that the funding again came from multiple sources, but predominantly from the UK's Medical Research Council and the EuroQol Research Foundation. We also had some support from local NHS in the UK. Now, the other kind of fantastic thing about this project was that we had a very broad range of governance and consultation support. And we had an international steering group of academics and key stakeholders. We also had a very large advisory group who were mostly able to input online. And that included a broad range of stakeholders, including HTA bodies. We were also fortunate because of our close relationship with the EuroQol Group. We had a lot of input from the EuroQol Group's working groups and the broader membership across the EuroQol Group. We also had a patient to public involvement group, which was made up of patients and carers and members of the public. And they stayed with us throughout the duration of the project, meeting regularly to discuss and input at different stages of the project. We also had some engagement with NICE Citizens Council to get their input at different stages of the project. So that's kind of set the scene for the size of this project and the breadth of input that we got across a range of different people with different backgrounds from different organizations and with different expertise. So what I'm presenting today is very much a collaborative exercise. So this new instrument that we were aiming to make, we wanted it to reflect both health and other aspects of quality of life that could be impacted by social care interventions or interventions that may impact on carers. So we were thinking that we would need to make sure the core aspects of physical and mental health are covered, but also broader aspects of quality of life and well-being. And what we wanted in relation to what that remit of quality of life was those things that were judged to be important by the service users themselves. So that's by the patients, by the social care users, and by informal carers. There were also a number of constraints on the instrument because we knew we needed to use it in the future in clinical trials and in routine surveys. We wanted it to be able to be translated to be used internationally. And so right from the outset, we thought, well, one way of making sure we cover the breadth of quality of life that's likely to be important to people but also come up with an instrument that can be used in clinical trials and can be used to measure the Q part of the quality or give us a utility score. One solution to kind of combining those different constraints was to produce two instruments. One that was short enough to be valued using our standard measures. And we were obviously particularly interested in using the same measures that have been used to value EQ5D, but also a longer version that in the short term, we had no plans to put onto a utility scale, but of course, that might be something that hopefully can be done in the future. Okay, so these are the stages of the project, and it's worth saying we simply really followed good practice in relation to instrument development throughout the development of the EQ5D, sorry, EQHWB. So we began with kind of setting out what's going to be in the instrument, what are the domains. From each of those domains, we came up with a possible list of items that could capture each of those domains, and we put those items to some rigorous testing through face validity interviews with future users and psychometric analysis. And then the next step is the evaluation and continuing testing around the validity and understanding the impact of switching between different instruments. So I'm just going to give a very brief overview of some of those different stages. So the first step was the qualitative literature review. Here we're trying to really listen to future users and say what matters in terms of your health and quality of life. How does your health condition impact on your life? How does your use of social care impact on your life? So we really tried to bring in the qualitative voice of our future users. And the review was kind of targeted to sample conditions, because clearly this is a very big task. We're not just saying a single condition, we're saying key health conditions, both physical and mental. So that's a very, very big literature. So we had to be fairly selective in terms of the literature that we chose to draw on. Once that sort of large literature had been kind of sampled, we then used framework analysis to try and extract the key domains. And we're particularly interested in things that come up over and over again across different health conditions, because the aim is to make a generic measure. And so whilst there might be some aspects of quality of life that are extremely important in some conditions, we were looking for things that were fairly general across most health conditions. So from our sort of framework analysis, we then formed a kind of initial working conceptual framework around what we thought would be in the instrument. And you'll see this screen looks a little bit busy, and that's because we identified quite a lot of fairly broad aspects of quality of life. We kind of collected them into 7 higher level domains, just for kind of structural simplicity, really. But what we have is many subdomains, and they cover, not surprisingly, core aspects of health. And you'll see how actually all the core dimensions that have been talked about already in relation to the EQ5D are included here. But they also include broader things like cognition and like relationships. And one thing that we found quite interesting was that these broader aspects of quality of life, so things like ability to cope and the extent to which you have control over your life, and your social engagements and whether you feel a sense of belonging, we were expecting them to be important, because we knew that they tended to be picked up in the instruments measuring carer quality of life and social care related quality of life. But what struck us as very interesting was the fact that actually these aspects of control and coping and belonging in relationships, in fact, they tended to come up for most conditions, both physical health and mental health. So there was a strong consistency in what seemed to matter for people's quality of life. So from that position, we then tried to identify items that could potentially tap into all of these different constructs. And that moved us to our stage 2, where we're generating the items. And we began really with trying to say, we don't want to reinvent the wheel. If there are good items that are already out there and already being used, then we would prefer to use them. If there aren't any, then we use the literature to help us make new items. We followed a fairly rigorous process of setting out the criteria that we needed for items to make a good instrument, and comparing those items to the set of criteria, and that took us down to 97 items. From there, we then went to test those items in face validity, and we tested the items across 6 countries with a mix of patients and carers and social care users to try and see what were people thinking when we showed them the items. Were they interpreting them in the way in which we were expecting them to interpret the items? Using the results from that, we found that about 30 of our items weren't working as well as we thought, and so we reduced our item pool down to 62. At that point, we then took those items out to a large survey, again across our 6 core countries, and collected data to enable us to do the psychometrics. And we used, again, standard psychometric processes of sort of classical psychometrics, where we're trying to look at things like missing data and the distribution of items. We used factor analysis to try and help us confirm whether or not the structure, the conceptual structure that we thought the instrument was picking up was being reflected in the items. And we used item response theory to help us try and identify the best performing items. We then had a very large amount of data for each item across all the countries, and we kind of tried to combine that data and present it to stakeholders. And the EuroQol Group was really instrumental in helping us access stakeholders to try and get their opinion, because we didn't want the final choice of items to rest on the research team. So we ran a couple of consultations to gather people's opinions on which items should be in the long instrument and which items should be in the short instrument. And you'll be pleased to know I'm finally going to show you what the instrument looks like. So this is items from the short instrument, which is a 9-item instrument, and it asks people to think about the last 7 days and then these different aspects. Most of them use a frequency response scale, so never, only, occasionally, sometimes, often, or most of the time, but some of them use a difficulty response scale. So that's the items that are in the 9 instrument. For the 25, we cover more breadth. Most of the items are framed negatively, but the ones in the lighter blue are framed positively. Now, there is ongoing work to come up with a value set for this. It's been piloted in Sheffield, and the valuation currently is being led by Bara Mukherjee, and that is ongoing work following the standard EuroQol Eq5D protocol. So just as with the Tandy, as Mike said earlier, this instrument is currently classed as experimental. It's an experimental version, which means that the EuroQol Group is interested in collaborating with research to build up evidence around its validity, but that it is potentially subject to slight modifications in the future. EuroQol Group has a special interest group around the potential future for this instrument, and that's led by Farah McCreary from Sheffield and Simon Pickard from Illinois. So it's a really exciting time to be involved in this instrument, because we're very excited that we think it has the potential to ultimately lead to good resource allocation in the areas of social care and bringing in carers and thinking about long-term conditions. But we're very much at the early stages still of that research path. If you would like to find out more, there's the website address here from the project website address, or you can contact that email address from the EuroQol Group.
Great. Thank you so much, Tessa. That was fantastic. I was a little bit worried about your own quality of life throughout then, because, but you did. That was great. You managed to cope all the way through, and great information. Now, again, I'll just ask Ore while we move towards Juanita. Again, I think most questions have been picked up. Oh, yes, we will drop the link from Tessa's final slide into the chat for sure. Ore, were there any specific questions?
There was one question regarding the possibility of using this instrument in sub-Saharan Africa, and I think that relates a bit more broadly on the stage of development of the instrument and whether there is any evidence that we should produce for this to happen, and what do you think more in general about the usefulness of starting such kind of work?
Sorry, can you just tell me the very first bit? Was it in relation to value sets, or was it in relation to translation?
It was in relation to translation, but broadly they use. They just ask whether the application of the QHWB and the QHWBS could be useful in sub-Saharan Africa, and how that would happen fundamentally.
Yeah. So as I mentioned, the instrument still has experimental version status, which means that we really think it's important to build up some evidence of its validity. And there is the potential that that might flag problems where we then might need to make slight adjustments, either to the layout or to slight adjustments to the wording. So there's a sort of sensible caution in terms of collecting too much data or spending too much money on translations until there's a little bit more certainty around the validity of the instrument in its current form. That said, going forward into the long term, it would obviously be great to have more translations and to have more evidence as to whether the instrument was relevant and valid in other country contexts. It is just worth saying that the original literature review from which we drew the domains was based in a sort of more Western context. So I think it's going to be very important to test whether or not the instrument is valid in other countries.
Great. Thanks so much for that, Tessa. And there's a great note to finish on. In the interest of time, I think we'll go on to Juanita's presentation, which is moving to a slightly different version of EQ5D. So instead of talking about the development of new instruments, Juanita's going to give us a presentation, which I think is a really nice example of the use of EQ5D and how it can be used in health and social research. So I will pass on to Juanita. Are you able to share your slides? Oh, and I'll introduce you while you're doing that.
Yes.
So yes, Juanita is an assistant professor at the Department of Public Health at Erasmus University in the Netherlands. She's has expertise in health technology assessment and implementation, and has a lot of experience in psychometrics and the use of EuroQol. And she's currently a principal investigator for this population health impacts of COVID studies, which is popularly known as the popcorn study. So I'll now hand over to Juanita, and thank you.
Thank you, Rosalie. Thank you very much for the invitation to talk about the popcorn study. So the popcorn study is an acronym for the population health impact of the COVID-19 pandemic. And today I'm going to talk about our study design, but also our results. So first, what were we investigating? So we were investigating the indirect impact of the COVID-19 pandemic on the general population. So you have the direct impact, which is people getting ill from the virus, for instance, but you also have the indirect impact. And this can happen because of the fear of infection, so fear of getting infected or fear of transmitting the virus to somebody close to you. It can also lead to unhealthy behavior. For instance, if you're locked up in-house, you can't do any exercises anymore. There's economic uncertainty and job loss, discontinuation of usual health care, and also those measures such as quarantine, social distancing, and lockdown restrictions. And each of these has an indirect impact on the general population. So that was what we were investigating in the popcorn study. Well, the stringency of the government response is something we were particularly interested in. The stringency measures are the measures that are imposed by the government to contain the spread of the virus. And each government reacted in their own way and with different restrictions. And they were all very nicely summarized in a component called a Stringency Index. And this is a summary score of 9 indicators, like, for instance, closure of schools, workplace closures, and cancellations of public events. These are only 3 examples of those indicators. And the Stringency Index ranges from 0 to 100. And 0 is no restrictions at all, and 100 is the most stringent that is possible. You can find this stringency tracker on the website that I show here. It's very nice. You see all the stringencies per country, but also over time. So in this slide, I show an example of 3 or 6 European countries, for instance, Italy and France. And here you can see the stringency of the government responses over time. And this is in the beginning of the pandemic, from approximately January to April 2020. So really at the first wave of the pandemic. And here you can already see that both the stringency differed over time per country. So you see differences per country in the same time frame, but also over time in the same country, you see differences in stringency. And this was something we took into account in our study. So the aims of our study, of the popcorn study, were to assess the health-related quality of life and mental well-being. And this is not the EQ health well-being instrument, but mental well-being of the general population of 8 countries. And we wanted to compare the health-related quality of life and the mental well-being of healthy and diseased persons in countries with different stringencies. So we could investigate the impact of stringency. We also wanted to identify risk factors for worse health-related quality of life and mental well-being. So we could identify the vulnerable groups in the general population, and also per country, of course. So what did we do? We selected 8 countries that varied in stringency of measures. We selected these countries, so Italy, the United Kingdom, Netherlands, Greece, Sweden, the United States, South Africa, and Russia. We performed, of course, an online survey because at that time, during the first wave of the pandemic, we couldn't do any face-to-face surveys. So we had an online survey, and the participants were selected from large existing internet panels of a market research agency. They were aged 18 to 75 years old, so adult respondents, and we asked, we composed them in such a way that they were representative of the population of the selected countries with regards to age, gender, and educational level. We collected the data in most of the countries end of April and beginning of May in 2020. And in Russia, South Africa, and Sweden, we collected the data slightly later, namely end of May and June. So we're here in the first wave of the pandemic. So we collected information on socio-demographics, so age, gender, educational level, income level, COVID status. This was self-reported COVID status, so have they been ill or not due to COVID, essential worker status, job loss, access to healthcare, and also, for instance, self-reported chronic conditions. We also collected information on health-related quality of life, which we measured with the EQ5D5L, and the mental well-being, which was measured with the WHO5 index, which is also called the 5-item well-being index. And we collected data on stringency derived from the Oxford COVID-19 stringency tracker, which I showed you the link to in the previous slide. So these were the data that we collected. So we had 2 outcome measures here, health-related quality of life, measured with the EQ5D5L, and mental well-being measured with the WHO5 index. Well, we had more than 20,000 respondents to our survey, and here you can see the respondents per country. Most respondents were from the Netherlands, with more than 32,000 respondents, and least were in Greece, because it was quite difficult to find respondents representative of the general population aged 18 to 75 in Greece. So that's why that panel and also the one in South Africa were a little bit smaller than the panels in the other countries, or the number of respondents in the other countries. The median age of the respondents ranged from 33 years old in South Africa to 49 years old in the Netherlands. Approximately half of the respondents had a chronic condition, and with this I mean like conditions like rheumatic arthritis, asthma, cardiovascular diseases. And we also asked them if they were infected with COVID-19 or not. And here you can see that this ranged quite a bit between countries, with the lowest number of people reporting to be infected with COVID in Russia with 6%, and the highest in Sweden with 22%. For each country, we checked if the respondents with regards to age, gender, and educational level were representative of those of the general population. So here you see an example of the Netherlands. In the left graph, you see the population of the Netherlands reported by the United Nations, and you see the percentage by age category and by gender. And in the right-hand graph, you see our data. So it's slightly different, but we tried to have at least the same shape in our figure. Okay, and here you can see some of the results of the EQ5D5L and the WHO5. And mind you that here we transformed the scores to a 0 to 100 scale. So instead of 0 to 1, which was explained by the previous presenters, we here just multiplied by 100 for the EQ5D5L index. So we had the WHO5 and the EQ5D5L on the same scale. Here you see the median EQ5D5L index score, and the highest were found in South Africa, the Netherlands, and the United Kingdom, and the lowest in Sweden and Russia. But if we look at well-being, we see some differences in countries. So here we see that the Netherlands and Greece and the United States have the highest mental well-being, whereas it is lowest in Sweden. So here already you see differences between the WHO5 and the EQ5D5L, which really nicely shows that you're measuring different concepts with the 2 measurement instruments. Okay, in this picture, I will just briefly explain what you see here, because I can imagine it's quite confusing if you look at it for the first time. We here subdivided the people into those that were healthy and those that were diseased. And with diseased, I mean people with chronic conditions like the asthma, the rheumatic arthritis, etc. And in the left-hand figures, you see the results of the EQ5D5L index for the healthy people. And we also have them by age category, which you see at the bottom of this graph. So 18 to 24 years old, 30 to 34 year old, etc. and by Stringency Index, which shows the colored lines. You see here that the EQ5D5L index for the healthy people is quite high. So it's also what you expect. They're higher compared to the diseased ones in the right graph. And you also don't see a big difference between stringency of the country. All the lines are overlaying each other more or less. But if you look at the disease, so in the other graph on the right hand, there you see quite some differences. You see that overall the EQ5D5L index is lower compared to the healthy people, which is what you would expect, of course. And you also see that people living in countries with more stringency, so a higher stringency, have a higher EQ5D5L overall. And this you see for all age categories. So the purple and the blue lines, which represent the most stringent measures in the countries that we selected, they have the highest EQ5D5L, and the countries with the lowest stringency, like the orange and the sort of brownish colored lines, have the lowest health-related quality of life by age category. If we look at the same picture, but then for mental well-being, we then see that it's actually quite a different picture. So the healthy people, they don't have 100 or somewhere around 100. They all also have non-optimal mental well-being. And you also see quite big differences between the stringency of the country, and also quite a big difference or a sort of age gradient for the age categories, with lower mental well-being in the younger age groups versus those of the older age groups. For the diseased, you see this age gradient even steeper, and younger people who have a chronic disease have a lower mental well-being compared to those who are older. And also what we see here is that the more stringent, if you look a little bit through your eye hairs, the more stringent countries have also, the respondents of those countries also have lower mental well-being. We can also look at the responses per dimension of the EQ5D5L and the WHO5. This is also very nicely explained in the book on data analysis of the EQ5D that Nancy Devlin just mentioned. So you can look either at the EQ5D5L index, where you summarize all the dimensions into one figure, or you can look at them separately, which we did here in this spider chart. So MO means mobility, SC means self-care here, UA means usual activities, PD is pain and discomfort, and AD is anxiety and depression. And here we show the number of respondents that reported any problems on each of the dimensions. And you see here that for mobility, these are again the healthy respondents, so not the people with chronic diseases, but those who are healthy. Mobility, self-care, and usual activities, only very little people report problems on these dimensions, whereas with pain, discomfort, and anxiety, depression, you do see quite a big impact for these healthy respondents. So quite a number of people, of our respondents, report problems on these two dimensions. And you also see differences per stringency. So you see more anxiety and depression, or more respondents reporting anxiety, depression problems in more stringent countries. On the bottom half of this circle, you see the dimensions of the WHO5 mental well-being. And here you also see that there are more problems reported on the WHO5 items if the country is more stringent, so if there are more stringent measures in the country that the respondent is from. So this is also a way of looking at EQ5D data that really informs. And I think this also shows that where we didn't see a lot of differences, if you look at the EQ5D5L index, you do see quite some differences if you look at the dimensions, and particularly the dimensions pain, discomfort, and anxiety and depression. Now, if we look at the respondents with chronic disease, so the people with asthma, for instance, or rheumatic arthritis, you see, of course, much more people reporting problems on any of the dimensions. So, for instance, here, people also report problems on mobility and self-care and usual activities. But also, the more stringent the country is, so the blue and the purple line here, the less problems people report on these dimensions. Whereas with pain and discomfort and anxiety, depression, you see actually the opposite. So more people reporting problems when it's more stringent. And people also report more problems on the WHO5 items on the bottom half of the graph here. We also looked at risk factors for the EQ5D5L and the WHO5. And here we saw that younger age, female gender, having a chronic disease, middle or low income level, unable to work, and living with others, not feeling protected against COVID-19 and experience low quality of healthcare are vulnerable. So people who have this have a higher risk of lower EQ5D or lower WHO5, so lower health-related quality of life and lower mental well-being. And the red colored or the red lettered risk factors had the worst impact. So particularly people with chronic disease who are unable to work and people who do not feel protected against COVID-19 and people who have experienced low quality of health care have particularly worse health-related quality of life and mental well-being. We also saw that stringency has a small positive effect on EQ5D5L and a large negative effect on the WHO5 mental well-being index. But of course, as you already saw that with the EQ5D5L, the index score shows some different results than if you look at the results per dimension of the EQ5D5L. So I think that if you look at the index score, it obscures some of the differences that there are in the dimensions. Oh, sorry. So our discussion is, does stringency of the government response against early COVID-19 make a difference for the population health? Yes, is our answer, but there are different effects among healthy and diseased respondents, which we showed, and also the direction and the magnitude of the effect depends very much on the outcome measure that is used, and also how you look at these outcome measures. So if you look at the EQ5D5L index, or if you look at the scores per dimension. Of course, our study had some limitations, as all studies do. Possibly there's a selection bias because we used a web-based survey, so we needed to have people who were online and who were also member of these panels. And also there's non-response bias. Our questionnaire in the end was, of course, quite long, and maybe people have started the survey but didn't end it. We have information on this, so we were able to look into this. So if there was actually also a non-response bias, and if there were some groups who didn't fill out the complete survey compared to others. The chronic conditions were self-reported. This was a very important variable that we used in our studies, but it was self-reported, which of course has its limitations. And at the time of sampling, mass testing of COVID-19 was not available in the general population in most of the countries that we included in our study. So that means that there's less certainty about COVID-19 status. It was self-reported, which already gives some more uncertainty. But if people don't know because they have not been tested, so they think they may have had COVID-19, they may have had said, yes, I did have COVID-19, but maybe in reality they didn't. Also, the questionnaires were available in one main national language in each country. So that may also lead to some people not being able to complete the survey. For instance, we didn't have a Spanish version in the US. And also younger males were underrepresented in our sample. Okay, of course, I didn't do this study on my own. I had a very nice team that I could collaborate with. And here you can see the members of our popcorn study team. And the funding for this study was from the EuroQol Research Foundation. Okay, this completes my presentation. Do you have any questions? I didn't look at the chat in the meantime, so maybe somebody can assist me with that.
Thanks, Juanita. I find this research absolutely fascinating. So it was great to see this presentation. There is a question from anonymous attendee. So it's saying, are you able to consider the level of support provided in these countries, as that would interact or even inform the level of stringency and impact on overall health and well-being? I know that was certainly relevant in Australia, but yeah. So how much support the government provided?
Yes. The stringency index that we used had 8 indicators, but there are also more comprehensive indicators of the same research group that also take into account those types of variables, like government response with regards to economic certainty for the people living in the country. I think that's what you mean, right?
Yeah.
Yes.
Yeah. Well, I think that's what is meant. Yes. Yeah. I might just add a question too, although I'm just checking to make sure that there aren't other questions, and I'm sure Ora is as well. So have I interpreted it correctly that that the difference is really that it's almost as though the effect of COVID and the stringency effects almost pivoted what happened between diseased and healthy people? So almost as if the way that I would see it is, to some extent, if you have an underlying condition, you may be felt less impacted by the stringency of the measures because maybe you felt as though that was doing something to protect you, which healthy people maybe didn't feel. Would that be a fair representation of that?
Yes, well, we have thought about it quite a lot. And also, since another study that was performed in Canada found the same thing, so that overall, looking at the index, you don't see differences, but by dimension, you do see differences. So one of the explanations may also be that if you have problems with walking around or self-care, but you don't have to go anywhere because you can't go anywhere because it's so stringent, actually you have to stay home all the time, you are not confronted that much anymore, maybe with not being able to walk, not being able to do the self-care. Because if you, for instance, work from home, you don't have to be very quick because you have to go with the train or something. So that's something that we and also the researchers from the Canadian study considered, since we saw the same pattern. So it could be that because of the stringency and because you have to stay home, you don't encounter the problems with mobility as much as you would do normally. And you can compare them much more with other people who can walk. That would be my interpretation. But of course, we want to research this much more in future.
So that's a fantastic point. Also, so somebody's asked in the chat whether we can share a link to the report of this research. I think there's papers coming out, aren't there?
Yes,
so,
yes. Yeah, we have submitted the papers and we hope to be able to share a link to a published paper soon. Yes.
Yeah. I did have another question and now I've forgotten it because I got distracted by that. I was going to say, if we could get the other panelists to turn on their cameras in case there are other questions as well. What I was going to say is that was a great point about the different impacts as well. There were, Ora, I might just check with you whether there were other questions that it might be worth raising. I remember there was the question about using the pit state that we passed over in the interest of time from Nance's presentation.
Yeah, there was a question regarding the choice of doing the anchoring based on the pit state and not alternative approaches, or the question was more broadly whether there are alternative approaches and why we have chosen this one, and what are the next steps.
Do you want me to comment on that, Rosalie?
For sure, Nance, yeah.
Yeah, just super briefly to say that there is kind of an open question there that remains about the best way of combining TTO and DCE data. There are a number of projects underway to look at alternative ways of anchoring using the data that are generated from the protocol at the moment, and looking at whether or not we can strengthen the means of anchoring, and by making better use of all of the TTO data which are collected under the current protocol, but also looking at whether extending the design or changing the design of the protocol would also further help with that. I guess the key thing is whether there are any prerequisites of decision makers, going back to that thing of consulting with decision makers, whether there are any prerequisites in terms of how they want anchoring to be done or what the anchoring means. It's a tricky area, but there certainly are alternatives to anchoring just on a single state, the pit state, and the most obvious solution to that would be hybrid modelling. And I think it seems fairly clear at the moment that in order to be secure in the estimation of parameters, you'd probably want an extended design compared to what we currently recommend in the protocol. So that's kind of where we are, but lots of research going on the way to explore that further.
And Juanita, I remembered what I wanted to ask. So I guess the thing that really strikes me about this research is as time goes on, and from Sydney, we're back in lockdown at the moment. I know South Africa is back in a strict lockdown. So it'll be really interesting. So what are the plans in terms of ongoing research to collect further data or continue the study?
Well, thank you so much, Rosalie, for this question. We have actually collected data in the past month among the same respondents of the Popcorn 1 study. So we can follow them over time and see how they're doing now. So looking in a later stage of the pandemic and also checking if, because of course the stringency has also changed and was different in the past month in most countries than in the previous measurement point. So we hope to answer some of those questions in our next study, which was also actually funded by the EuroQol Research Foundation.
Thanks, Juanita. And there is another, not so much a question, but a comment around the representativeness of the sample in South Africa, given, I guess, income inequalities and access to internet and those issues for many Black South Africans.
Yes, we have had large conversations with that, also with the Market Research Agency. We were able to make a questionnaire that people could also access on their phone. So people are able to answer questionnaires on their phone using the platform that we used. So hopefully that already lowered the threshold a little bit. But of course, there are many limitations to the representativeness, particularly of a country like South Africa and also, I think, Russia. So we're very much aware of that. Yes, yeah. But unfortunately, no other ways of collecting data were available at that moment in time.
Great, thank you. Now, I'm conscious that we are at the witching hour for this session. We could go over, but I realized that people, organize their time around it, and also that people are at all different time zones across the world in this session. We've had, I can see that there's been a wide range of participants and attendees in the session. So I really hope that for those attendees, this has given an overview of the work of the EuroQol Foundation, the instruments that EuroQol has available for measuring and valuing health, and also the ways that they can be used. And as we've said, this session will be available, so you can download or replay it again if there are particular things, or please get in touch with any of the panelists. We'd love to hear from you. And thank you, everybody, for attending. And thank you particularly to Mike, Juanita, Nancy, and Tessa, and to Ore, who's in the background answering the questions, for a really great presentation. So thank you.